Well, good afternoon, everyone. I hope you guys are all having a great day. Thank you for all your presentations. They've been so good so far. I'd like to first acknowledge that I'm calling in from the unceded and ancestral territories of the Wasanich peoples. And today I'm presenting on my Culminating project titled A Creative Approach to Public Health, which really focuses on promoting innovation within public health practice. I was able to have the opportunity to work within the Ministry of Health of British Columbia alongside the Collaborative Innovation Team. And this team really focuses on using a human-centered design approach within their practice. And this approach centers the intervention or the policy around the end user and uses tools to assess their needs, experiences, and behaviors to gain a more comprehensive understanding of the user as well as the context. So in public health, traditionally, at the start of creating policies or interventions, we start with the problem and declaring the problem. However, with human-centered design, this approach pulls us back to start with empathizing with our user to gain that comprehensive understanding of them, as well as the challenge, meaning that it prompts us to demonstrate humility and admit that we, even though we may be experts in the area, may not truly know what the problem is ourselves. It pushes us to go out and seek what our users want and why they want that, to figure out their needs collaboratively, and then co-define the problem, and then co-create the innovative solutions. So a really popular example within human-centered design approaches and thinking is when Henry Ford stated that if he had asked his customers what they had wanted, they would have said faster horses, when in reality, what they needed may have been like a car. So using a human-centered design approach, it allows us to use tools to collaboratively understand why our users want what they want, and then decipher what they need together. This helps recognize that even though users might not be able to verbally articulate what they need, they can often demonstrate what they need through reveal the true issues through their actions, behaviors, thoughts, and feelings, to then co-define the problem and co-create solutions to make really sustainable and effective programs and policies that really tailor to the perspective and experiences of the users. So with the Collaborative Innovation Team, which is the team that I worked with, what their goal is they introduce program areas within the ministry to new and collaborative ways of thinking and working. So putting them in a more creative mindset and space. And they help build an understanding of why human-centered design methods and approaches are so important. And they focus on building the ministry area's capacity and empower them to use these methods within their work and with their partners. I think that it's important to say that, this approach is not widely used within public health, mostly due to the fact that it is quite resource and time intensive. But I knew that I really wanted for this project to align with their capacity building goal. And so essentially what I did was I developed an educational resource toolkit to help them empower people within the ministry, so our viewers of the tool, to use a human-centered design approach and tools within their work and with their partners to then, increase their knowledge and understanding of what the tools are in the approach, what their benefits are, and how to use them within the context. So the way that my project kind of came to be is I started with consulting with my colleagues and, identifying what is my resource kit going to consist of? What tools am I going to talk about? And then I conducted research and figured out, the essence of the tools and the approach and how it can transfer, because it's predominantly in business and technology. And so figuring out how to transfer it into public health. And then, of course, identifying ways that I wanted to convey the information. And I think this was a really important part for me because I really wanted it to be inclusive and accessible and accommodate a wide variety of learning styles. And then, of course, for implementation, I wanted a strategy that would get it in the hands of as many people in the ministry as possible. So first up, consulting with colleagues. This consisted of primarily asking questions such as, okay, you have so much experience with people in the ministry. What tools have you seen have great uptake with ministry program areas and their partners? What tools have yielded really successful results? And we landed on the sailboat retrospective tool, empathy mapping, and storyboarding. So like I said previously, it is predominant in business and technology. So I had to first off learn about this approach because I had never even heard of it. And I used the service design manual, which is just a manual that is about human-centered design, and it's accessible for the entire government, as well as read scholarly articles, both in the business side as well as in the healthcare setting. And I consulted with my designers on my team, and I actually got to facilitate sessions with program areas and their partners to actually utilize this tool with them, which was fantastic, and building my capacity to be able to then teach everybody else how to use them. So it was great. So the next thing I did was I identified ways that I wanted to convey this information. And I went back and forth on so many different ideas, but I landed on a blog post series. And so it was one post for every tool that I had picked. And so this blog post series I really resonated with it because I loved the idea of conveying this information in a conversational manner rather than a scientific article with a whole bunch of jargon. And it allowed me to add this element of storytelling in it as well. So really engaging the readers as well as making it a little bit more digestible. So the post really answered, what is the tool? What are its benefits? How do I use it? And how does it relate to public health? But I knew I didn't want to stop there. So I embedded mural boards within the blog post for those who are more visual learners. And so what this allowed me to do was visually break down everything within my blog post, but add more detail than a 1 to 2 page post would allow me to do. So I was able to provide examples of the tool in scenarios and context and provide them with templates that they could copy over to their own mural boards, which is a very popular whiteboard in the ministry, just FYI, and use it with their partners. But I also didn't want to stop there. So I created learning activities to embed in the mural boards for those who are more kinesthetic learners and have to kind of apply their knowledge to have a good understanding of the tool. So after every little chunk of information in my mural boards, there would be a new learning activity, which was a couple questions and allowed them to critically apply what they had just learned, reflect if they have any gaps in their understanding of the tool. Do they have to go back? Do they have to ask us questions? So hopefully with the idea of it engaging people more with the tool and promoting knowledge uptake. Next, I also designed a workshop to go along with the tools. However, just due to the short duration of the practicum, I was only able to do one on the empathy mapping tool. It was collaborative throughout the entire session. It was not just me lecturing to everybody. It was collaborative discussions throughout the entire process. And we all filled out an empathy map with a scenario and a persona together. And it was so great for auditory learners and kinesthetic learners as well. So for implementation, I talked to my health internal communications team as well as my collaborative innovation team to think about ways that would host this tool that would make sure that it gets in the hands of as many people as possible. So we had the newsletter, which was allowed for a quick read of a blog post to land in everybody's mailbox in the ministry. The Health ePlace, which is an intranet for all Ministry of Health people where it could live concretely. People could access it whenever they wanted to. People could complete the resource at their own pace, which was great, as well as the Community of Practice, which is more of just a place on the Microsoft Teams channel where it's more of like promoting all these new things. So it's a really high traffic area. So that was really great too. So those were kind of my results and findings for my process and my methods, but I really wanted to showcase one of the tools, and this is a storyboard. So storyboarding visually represents the user's journey and experience with the service, and it helps us as practitioners identify key touch points, barriers, and opportunities for us to intervene. So it can also help visually represent experiences that can be really challenging to articulate verbally. So here we have a food insecure student. I'm giving you a little context there. She is hungry visibly. She's looking in her fridge and in her pantry. There's no food there. And so she's heading to university. But as she's about to go into her lecture class, the student union booth is handing out newsletters and it says new food pantry now open. So she's Googling it on her phone and it says free food for students open 9 a.m. to 2 p.m. But she's thinking, oh no, I have class from 9 a.m. all the way to 2:20. So in the next slide, it's 1:30, class is about to start, and she's having this internal conflict of, do I deal with the consequences of skipping class, or do I deal with the consequences of, not going to the pantry? And so in the storyboard, she ends up going to the pantry, which is great, but this shows one user's experience with this potential program. And so here we can identify the barrier, which is, the student would have to choose and deal with the consequence of either. But it also highlights an opportunity for us to be like, okay, I see the issue here. Maybe if we develop food lockers where she can access it, or food lockers. And so essentially what a food locker is that they would be allowed to put the food package in the food locker. And so she could access it outside of the pantry hours. So that's just a little example of how it can be used in public health. So for my discussion, I think it really does underscore the need for this departure from traditional approaches that are top-down directives, they're expert-driven, to more inclusive and collaborative ways of working. And I think it highlights as well that there needs to be a strong focus on increasing the capacity of health practitioners to use these kind of methods to inform equitable policies and services that are tailored to the needs and experiences and perspectives of the users to increase uptake and, of course, satisfaction as well. And overall, I do think it does, by disseminating this information through the resources, it can foster a culture of innovation within public health. So overall, I think this project does highlight the importance of using these methods when developing health policies and services, and it highlights the relationship between equity, sustainability, and human-centered design, and overall contributes to this broader movement towards embracing a more innovative and responsive approach to public health. I just want to give a big thank you to my supervisor, Annalisa Blake, and my entire collaborative innovation team for exposing me to this new approach and making me so much better of a health practitioner. And I want to also give a big thank you to Dr. Hamie Lira and Heather for making this a seamless of a experience of practicum. It was fantastic. So thank you so much.